This is part 2 of the child with respiratory dysfunction, and we're still in upper airway, and we're going to move on to influenza. So, you know, you've had the flu, right? The clinical manifestations: fever, cough, chills, body aches, similar to a cold but more severe. Most of the time this stays in just the upper airway, but it can turn into a viral pneumonia, and that's when people end up hospitalized with it. So how are we going to treat it? Well, it's a virus. Let it run its course, right? Fluids, rest, Tylenol or ibuprofen for pain and discomfort and fever. We do have some antivirals that can be used. Simitrel and Tamiflu. They need to be started within ideally 24 hours of the onset of symptoms, but no more than 48, or they do nothing. If they're started early, they will shorten the duration of the flu. We also have some that are inhaled that are the same sort of thing, treatments that need to start early. The best thing we can do is prevent the flu. We have flu vaccine. We give it to anyone over 6 months. The flu changes every year. Viruses mutate rapidly, so that flu shot, they give you the three worst flus they're expecting that season, and they kind of watch them because flus migrate around the globe because they're predominantly in the winter season, so they can tell from who's been in winter right before us what is probably coming to us, and they give us the three worst ones so that we have some immunity against those. So if we do get those, we'll get them mild. There are other flus out there though, so if you've had a flu shot and say, I still got the flu, well, you didn't get the worst ones that we were expecting that season. With kids, an important consideration is no aspirin, right? ASA, acetylsalicylic acid, is the chemical name for aspirin. Aspirin in a viral illness, flu and chickenpox being the two biggest culprits, can lead to Reye syndrome, which is permanent neurologic damage. Reye syndrome is rare, but because it's devastating, we avoid that. Otitis Media. This is considered an upper airway infection because that Eustachian tube goes from the middle ear to the kind of the nasal pharynx area. It's supposed to drain out any fluids that are in the middle ear and allow air in. The middle ear is filled with air. If you remember those three bones that vibrate, they're vibrating in air. When they're in water or serous fluid or purulent fluid, they can't vibrate as well, and it affects your hearing. So what happens, that Eustachian tube swells a little bit, so fluid that comes from just normal working of the tissues in there can't drain out. All the air that's in there gets used up, and so you initially get a vacuum in there that will retract the tympanic membrane, and then that fluid, germs from the throat, kind of, you get that vacuum, they get pulled up into it. Now they start multiplying it inside that fluid in the middle ear, and then you get that red and bulging eardrum that's full of purulent fluid behind it. So that's what happens. Most of the time, what's in there is viral. This is usually part of a cold. You swell those Eustachian tubes shut, you get some fluid in there, the virus finishes, they open, it drains. They can look infected or either retracted or a little bit bulging because you start making that extra serous fluid because you're doing the normal cellular metabolism without air. But usually it's a virus. And because of that, the current recommendation is to not give antibiotics too quickly. Children under 6 months, they'll still give antibiotics right away. Or if the child looks acutely ill, they come in. Those of you who have kids, you know that look where your kid is too sick to play. They just look ill. But ear pain, a red tympanic membrane, they're going to try and wait 72 hours. And that's hard to convince parents that that's okay, but it really is, because most of the time it's a virus and the antibiotics won't help anyway. And all we're doing is sensitizing germs to our antibiotics. So for those kids who really do get recurrent otitis media that we cannot resolve, we're going to do surgery. That surgery is tympanoplasty. So we're going to take that tympanic membrane and make a little slit in it, and then we're going to insert tubes, myringotomy tubes. And some of the prevention for otitis media is avoiding secondhand smoke. I said this earlier. Smoking is terrible around kids. Everything's so small that just a little bit of irritation and inflammation is enough to cause big problems, whether it be ear infections, chronic colds, asthma. So smokers need to smoke outside when there's children in the home. And bottle propping. You can imagine sleeping with fluid in kind of the back of your throat. When you're an infant, that's right where the Eustachian tube empties out, and it's supposed to be letting air in, and instead you've got formula there blocking it. So bottle propping is another bad thing. And here's just kind of a picture of the ear, right, your ear, outer ear here, the ear canal to the tympanic membrane. Here's those bones in the middle ear, and then your cochlea is back kind of deep in here, which is where the sound waves come in, turn into vibration, which turns into neurostimulation in the cochlea and then up to the brain. And here's the Eustachian tube. And the bigger, longer your face is, the longer that tube is and the more downward angled it is. Where on a child, it's small and relatively flat, especially if you're laying down. And then here's the semicircular canals, which are balanced. And here, this one's the cochlea. Here's some pictures of tympanic membranes. I have looked at many in my career, and doggone it, they rarely look this clear cut. This is what it should look like. A nice shiny white. We get this light reflex here. The tympanic membrane is so thin, you're literally seeing the bones, those 3 bones, through it. So they call it a pearly white with the light reflex. This is red. This is bulging out because it's full of purulent fluid in there. And most of the time they're somewhere in between the two, which makes diagnosing ear infections quite a bit of just a call on the, it's not always clear cut. Most of the time it's a judgment call. So moving on to, I didn't say on those ear tubes, our goal is to make a little hole that allows air in so that middle ear starts working in air again like it's supposed to. And if you do get an infection, it can drain out the tube rather than down the throat, since that is probably blocked. Most of the time, just breaking that cycle of chronic ear infections and you're good. You kind of let everything heal and it's fine afterwards. The ear tubes only stay in for a few months. They fall out on their own. They're angled so that they will fall out, and they rarely last more than a few months. So you're just teaching parents to look for it, in the child's bed at night, things like that. But it's not a big deal when it falls out. Usually we're fine after that. So moving on to infectious mononucleosis. This is described by what happens with the blood, but this is usually caused by the Epstein-Barr virus, and it's spread by saliva, and which is why they call it the kissing disease. It also happens frequently during adolescence, both probably related to that sharing saliva, and just that's an age where their immune system is a little bit compromised. They're having rapid growth, they're not eating well, they're not sleeping well. In the early stage, it looks like strep throat. It starts out with swollen tonsils with white on them and look terrible, and then it goes on, that resolves, and it turns to just fatigue. Anybody who's had mono will tell you it took them weeks, usually 6 to 8 weeks to feel better. What we're watching for, the concern is you can have an enlarged liver and spleen during it. Those will resolve on their own, but while they're enlarged, they're not protected by the rib cage like they should be. They're extending below it. And so any sort of direct impact to them, they are highly vascular organs which can bleed a lot, life-threatening internal bleeding if they're get a laceration. So rest to let it run its course, and then monitoring the spleen and liver. Croup syndrome. So now we've moved down to the throat. Epiglottitis is life-threatening of these. The others, usually not. So if we have swelling in our throat, you can get hoarseness, a barking cough, which is, I'm not sure I can do it well, but it sounds like a seal. It's kind of arr, arr, arr. And inspiratory stridor. And then depending how severe, respiratory distress. So epiglottitis, I said this one is life-threatening. This usually happens between 2 and 8 years of age. It comes on fast because it's usually bacterial. So they'll have throat pains, they'll have trouble breathing, so you'll see retractions. The kind of triad of symptoms for this is they're not coughing, they're drooling, and they're very agitated. They're sitting upright, trying to maximize chest expansion, and they look frightened because they are air hungry. This, the epiglottis, right, that's what closes, so when you swallow it goes down your esophagus, and when you breathe it opens to let you breathe through the trachea. The epiglottis is swollen. It can potentially swell shut, blocking your entire airway. We do not inspect the throat at all if there's a chance that it's epiglottitis, because that act of inspecting, having them stretch their mouth open, putting in a tongue blade, moving stuff around, you can make the swelling increase and cause a total obstruction. So instead they'll do neck x-rays, lateral, so from the side, neck x-rays. This usually is bacterial, so we'll do antibiotics, probably some corticosteroids for swelling, intubation, or if you can't get an ET tube past that epiglottis, they may have to consider doing a temporary tracheostomy, which is below the epiglottis. The most common germ that causes this is Haemophilus influenza, and remember there's a vaccine for that. So we see a lot less of this than we used to now with that vaccine. But if you do see it, it is life-threatening. Laryngitis. Kids don't get that. We get that as adults. The vocal cords get inflamed and you can't talk. You totally lose your voice. Usually you don't feel too bad. It's a virus. It will run its course, but you lose your voice. This is rare on kids. Teens may get it, but not kids. Our book talks about acute laryngotracheobronchitis. This is not a term that Valley Children's uses, so you won't see it called this at the hospital. But this is kids under 5, and it's all of our viruses. And basically you're saying you have some swelling through this whole area, the larynx down into the trachea and the main bronchi. And the same germs that can cause upper respiratory in the nose and throat can travel down. So because it's in the throat, you're going to get that inspiratory stridor, right? You're going to get retractions. You're going to get that seal-like cough, respiratory distress, and hypoxia. So this can become very severe, just depending on how bad it is. Often it can resolve on its own if it's virus and it doesn't get bad. So we're going to make sure we maintain an airway, that we keep them hydrated. Use that cool mist humidifier. We want to keep secretions thin so that they can be coughed out. And the treatment is to bring down the swelling. So this is a respiratory treatment, racemic epinephrine. So it's a nebulizer treatment, and then steroids. And that can be nebulized or oral or IV. We used to use a mist tent frequently in the past. It's not as common anymore, but you will occasionally see it. So we are blowing humidified air or oxygen or sometimes albuterol, if it's for asthma, in through here, and the child is inside of it.